Hi everyone, this is Tim, your lecture instructor for the Paramedic to RN Transition Program. And this voiceover is going to be on oxygenation, which follows your reading for this week, which is the respiratory system. What I've done is I've actually, created some slides pointing out the highlights of the different diseases. I hit most of them. There's a couple that I don't, but based on your reading, you'll go through them, and as I go through this PowerPoint voiceover, I'll also go through the book and point out some pages that I think are important for you to kind of pay special closer attention to. So, all right. So the next 5 slides are roughly the pictures of the respiratory system itself. So for the pulmonary system, we've got the lungs, we've got the bronchioles, we've got the lobes, and we have alveoli, and also the pleural space. Here's the diaphragm. So breathing in, the chest expands, ribs also expand, the diaphragm contracts, and with breathing out, the chest contracts, lungs relax, and so does the diaphragm. Here are your bronchi and bronchioles. Your bronchi are the larger trunks, and the bronchioles are the smaller ones. And for your alveoli and the capillaries, this is where oxygen is exchanged for carbon dioxide. And here's another picture of that, so that way you can see that CO2 is going out as O2 is coming in. So factors that actually affect the respiratory function is body position. You'll see in this picture the gentleman who's sitting in a wheelchair is kind of hunched over. This doesn't allow his lungs to expand, his diaphragm to actually work as efficiently as it really should. So when you have patients who are sitting in a bed and they're kind of hunched down like this, or they need to be scooted up and sat up in high Fowlers, that allows them to actually to breathe better. Other factors that affect respiratory function is also environment. So I put down here as an example living in Denver versus Phoenix. Denver has a very high altitude, so those who actually live there, because the air is thinner, they tend to create, their body tends to, based on homeostasis, will create or produce more red blood cells. And this is so that way they can have more, which will carry more oxygen, which will allow them to breathe better. Us living in Phoenix, we live below sea level, so our blood is a little thicker or thinner, and it's because of the weather and the heat. But we also don't need to have as much red blood cells as others. Air pollution also affects respiratory function. Those patients or people who live in different areas of the country, whether it be smog or the dust, or even here, when we have monsoon season and the haboobs are coming, that really affects those who either have chronic illnesses or those who have asthma or allergens or what have you. So those can also affect their breathing pattern. And that follows along with pollens and allergens. Lifestyle and habits. So smoking can lead to COPD and bronchitis and emphysema. As I mentioned in other PowerPoints, your biggest thing you can do is teach your patient the cause and effect of how they live, and smoking is one of them. So you may have a patient who has smoked, most of their life, but they can still, with some help and some education and some medication and stuff, they can actually stop smoking. And they may be too late. They may have COPD, but in the same sense, teaching them to stop will actually at least stop the worsening of the disease process. Other things that can actually affect breathing is drugs, whether it be legal or illegal. The reason why I put this down here is because for morphine and Dilaudid, you want to be able to make sure that when you're giving this medication that your patient has a good O2 saturation, make sure that they are able to breathe more than 12 breaths a minute. And so giving them a medication when they're not already breathing well is just going to depress that and make it worse. Ativan, which is an antipsychotic and also an anti-nausea medication, will also suppress the CNS. So you just gotta kind of watch out for it and make sure you're assessing your patient before you actually give it. Alcohol is the same way. Patients who consume way too much, it doesn't necessarily stop them from breathing, but it does actually slow it down because it actually relaxes all their muscles. Nutrition is also a big lifestyle and habit. Proper nutrition promotes healthy immune systems. So when you have patients who have chronic respiratory illnesses, the best thing they can do is actually eat as well and healthy foods so that way they can actually stay healthy and fight off infection. They don't need to get worse. It just came to mind as I was talking about or thinking about the flu shot. We want everybody to have the flu shot because it does reduce the risk of getting influenza. But those who actually have a poor immune system or have chronic illnesses like COPD, they don't need to get sicker, especially with COPD. It's their lungs, and any respiratory illness that they get on top of that is really detrimental. So your patient needs to be taught to do whatever they can to make sure they don't get secondary pulmonary infections, because add flu or pneumonia on top of having COPD, and it's horrible. Another thing is obese people have a harder time breathing because of the weight on their lungs, and this is pretty true. Patients who have COPD and also are very overweight, I mean, you have to figure between breast mass and an adipose tissue, it's harder for your lungs to expand and contract on their own, and it takes extra effort. So the bigger you are, the harder it is for you to breathe. And then if you add some exertion or exercise or something on top of that, it makes it even harder for them to breathe. So assessing your patient, things you can actually use, they have a pulse ox, which is the little device on the right-hand side, monitors arterial oxygenation, so the SpO2. We also have ABGs. We're going to go over how to read ABGs in class, so don't worry about that too much right now, but an ABG is one way of being able to assess your patient and find out if the O2 and the CO2 exchange is actually working. Another device is the peak flow meter. This measures peak expiratory flow rate. I didn't put a picture in here, but one other thing you can actually do is do a sinus spirometer. This allows you to determine if your patients are able to expand their lungs, especially after having surgery. Anesthetic will kind of depress the respirations and also kind of close down their lungs a little bit, and the sinus spirometer actually helps open everything back up. So for nursing diagnosis, we have ineffective airway clearance, ineffective breathing pattern, impaired gas exchange, and activity intolerance. What we'll do is we'll go through this in class as far as nursing diagnosis, and what I want you to do is when you actually read all the chapters for respiratory is to specifically look more at interventions and outcomes, because when you have problems based on these disease processes, you've got to figure out what to do to actually make that better, and whether or not it actually worked. If it didn't, then again, you're going to try something different. But when you read, like I said, when you read these chapters, I want you to particularly look at nursing diagnoses and interventions and the rationales behind them. So interventions, we have hydration. So you want your patient to drink 6 to 8 glasses of water a day. The more hydrated they are, the more it actually thins out the secretions. So this allows them either to cough stuff up, or it keeps them from actually being dehydrated and congested. You want to prevent them from having dairy because this causes a lot of phlegm and mucus. So the more they and it collects more in the throat than anything else, but that dairy, if they're already having a hard time breathing, you don't need their saliva and their secretions to be thick. You don't want them to actually have any caffeine because caffeine is a vasoconstrictor, and you want them to be as dilated as possible. The more your vascular system is dilated, the more blood actually flows, and you need to, for especially COPD patients or respiratory patients, you need to be able to take what they have and make it as efficient as possible. So COPD patients, they don't breathe real well. They don't actually exchange CO2 and O2 very well. But what they do have has to work as well as it possibly can. So again, you want the vessels to be as dilated, and you just don't need the caffeine to interfere with that. Positioning and ambulation. So again, bed bound patients, they need to be repositioned every 2 hours. This allows whatever fluid that is collecting in their lungs to be able to shift from one side or the other, and their body will absorb some of that stuff. Walking encourages deep breathing and strength. So those COPD patients, I wouldn't take somebody who is actually having a very hard time breathing, but those who are there for either an exacerbation or there for respiratory pulmonary issues, if they're stable and they're breathing okay, getting them up and actually walking helps circulation. It prevents DVTs. It helps, keeping their muscles strong and actually try to be as healthy as they possibly can. Laying in bed just allows them to break down. It makes them weak. They're not breathing as well as they should. It's not expanding their lungs as much as they possibly could. Deep breathing exercises will also help. This will expand the alveoli, promote effective cough, and decrease risk of atelectasis. Again, if your patient's laying in bed and they're not really having to take big, deep breaths because there's no exertion, then again, that's going to start fluid collection in their lungs. By actually giving them an ascending spirometer or a peak fluid meter and making them cough in such, however you can do it, it allows them to open up those alveoli. And it also kind of gets them to cough that stuff up and out. Again, I mentioned the ascending spirometer makes the patient take deeper breaths. You want to do this 10 times every hour. You can either have the patient do it during the commercial breaks when they're watching TV, or you can actually go in there every hour and make sure that they actually do it 10 times. But this tries to keep things as open as much as possible, and it keeps things moving. And again, if you can make them cough, makes them cough it up and out. Interventions, there's oxygen therapy. Patients that are COPDers tend to live around 89, 90% with 2 liters, and again, that's normal for them. So that's their therapy. Patients who come in with pneumonia or acute illnesses, again, you can put them on oxygen, just to supplement and make them feel more comfortable, but then you want to wean them off as fast as possible. So if you have a patient who came in with some sort of acute respiratory illness and is on 6 liters of O2, you want to kind of keep bumping them down daily after breathing treatments and antibiotics and stuff, because as they're getting better, they should start being tapered off that. We also have suctioning in oral care. Suctioning, it's really to clean out the gunk. Patients who are elderly or can't necessarily move the secretions themselves or spit it out will tend to inhale them or tend to swallow them. So the yonk, or the picture that's here, this will actually help you or even them actually kind of clear out those secretions in their throat and in their mouth. I've had some patients, particularly this last weekend, I took care of a patient who was 81 who had influenza A, and she had a very productive, moist cough, and it was actually pretty strong. But it was hard for her to actually cough it out. She was able to cough it up, she just couldn't get it out. And as barbaric as it sounds, it's easier for this, yonker to be used and kind of go back there a little bit and clean out, the soft palate and stuff. But then, you kind of have her take a big deep breath and you kind of, stick it a little bit further down there in order to actually kind of get what she couldn't. And it makes her gag and stuff. And I wasn't trying to be mean, but it did help get some of that stuff up. And she knew we had to do it, and she knew that she felt better afterwards. So oral care is also a very big part of not only hygiene that we kind of forget in our patients, but it's also really big on patients who are having respiratory issues. Things collect, and especially if you've got patients who are sleeping a lot because they're sick and they're tired and they're not feeling well, they will tend to get a lot of I don't call it crust or film, but there's a lot of that stuff that collects in the back of the throat, and they just need that oral care to be able to kind of get all that stuff out. So here's the cardiac system, which we'll cover, next week or the week after. I put this in here because the fact that you can see where the heart sits and where the lungs are, and the two go hand in hand. That's why when I put your test together, I put the two of these systems together, because they do kind of go hand in hand, and one does kind of affect the other. All right, so far as circulation in the respiratory system, hemoglobin carries oxygen, which you guys know. The arteries carry oxygenated blood to the tissues, and veins carry deoxygenated blood back to the heart and the lungs. And that's pretty simple. I mean, I just threw this in there to just kind of remind you how that all really works. So for respiratory disorders, I threw in valley fever because of the fact that we live in Arizona. I have taken care of patients in the past who have, for whatever reason, they decide to move here in September, October, and when we're high monsoon season and the boobs were coming, but valley fever is actually from spores in the actual dirt, and they tend to be dug up through construction or the boobs or whatever. And like I said, with these people who just moved here who are not used to our particular allergens, they're not immune to them. So again, I've had patients who have moved here in September, and then next, within weeks they've got valley fever. The other respiratory disorder is pneumonia. We've got tuberculosis or TB. We've got COPD, which is an umbrella for chronic bronchitis and emphysema. This poor gentleman, he definitely has the COPD, and he's sitting the way he is because it does expand his his chest and his abdomen as much as it possibly could, so he's able to efficiently breathe as well as he possibly can. So here's your valley fever, which I mentioned. It's a fungus. It's found in the southwest. It's found in the soil and the dust. Symptoms are fever, cough, chest pain, chills, night sweats, headache, fatigue, joint aches, and rash. I think the patients I've taken care of in the past, the fever is a true sign of infection, which it is. You've got the cough because of it being a respiratory illness. You've got the chest pain because of that the patient's coughing so much, and it's causing not cardiac chest pain, but respiratory chest pain. They'll have chills because of the fever. They'll have night sweats because of the infection. They'll have the headache, the fatigue, and the joint aches and stuff. I mean, I think that's just more kind of typical flu-like symptoms. So, like I said, I'm more looking at the cough and the fever, and they're going to have to do more testing to truly find out if they actually have valley fever, which is a fungal infection. Sputum culture and the blood test will actually determine that. And medications for it is diflucan, which is an antifungal. Let's see here. The next diagnosis or infection is pneumonia. It can be bacterial, viral, or fungal. It can be community community acquired or hospital acquired. It can also be aspiration pneumonia, which is basically for those who are very elderly or who don't have the ability to actually swallow correctly, and it causes them to aspirate on either food or water or wherever they've consumed in their mouth. So symptoms are fever, cough, chest pain, shortness of breath, fatigue, nausea, vomiting, and headache. Again, because it's a respiratory issue, you're going to have the fever because of infection, and you're going to have the cough and the chest pain. Diagnosis is going to be a chest x-ray. You're also going to do a blood test and a sputum test. The chest x-ray will determine where the pneumonia really is, whether it's all the lobes or if it's the right side or the left side. They'll do a blood test to see if it's actually gone septic or not, and they'll do a sputum test to find out if it is bacterial, viral, or fungal. Medications will be antibiotics. Antivirals, you can do Tylenol for reduce the fever, and you can do cough medicine to either suppress the cough or an expectorant to actually help loosen that stuff up so they can cough it up and out. The next disease process is tuberculosis. This can be either latent or active, which means that you're a patient who doesn't feel well, who has symptoms of some sort of respiratory issue, will actually come in, and that's active, and they'll do some testing and they'll find out they actually have it, or they've had it, they've taken the medication, they've gone through it, got over it, and it becomes latent or dormant. Tuberculosis is bacterial. It's found in populations of people who live in very close areas, whether it be prison or college students who live in dorms, homeless people who tend to kind of live in a commune that's very close together, whether it be tents or I won't say boxes, but just it's for people who are very close together and living in close quarters. Symptoms are a cough. They will eventually cough up blood, chest pain, weight loss, fever, fatigue, chills. So the cough obviously is because it's a respiratory issue. Coughing up the blood is, I believe, that they have had it for a long enough period of time that you start breaking blood vessels. Um, the disease itself will probably weaken some of the lining of the veins and arteries and alveoli. Chest pain is probably a combination of several things. It's probably the cough. The chest pain is probably from the coughing up the blood, and not being able to breathe real well. They'll have weight loss because they don't feel good, and they don't feel good for a very long period of time. The fever is because obviously they have an infection, and the fatigue is more of that, like I said, flu-like symptoms. They just don't feel well. Diagnosis is going to be a TB skin test. They'll do a chest X-ray. They'll do a sputum test. The quantiferon TB gold test is actually the definite, you know, only. I mean, you can tell whether or not someone has TB based on the other diagnoses, but the quantiferon TB test is the true way to actually find out if they have it, and it's a blood test. And they also do the T-spot. TB skin test, I mean, I think that's kind of a standard for everyone, and even patients who they want to rule it out or think they might have it. If the skin test comes up positive, that really just means that they've been exposed to it, but it doesn't necessarily mean that they actually have it. So medications to actually take care of this is going to be the isoniazid, rifampin, and the ethambutol. They must take it for 6 to 9 months, and it has horrible side effects. When you do your reading in the book, I want you to pay special attention to um, a combination of interventions and assessments, because that's what you're going to do for TB. But also, what I want you to pay attention to is the interventions as far as things that your patient has to do to get over this. They have to do this for 6 to 9 months, and it's pretty hard for them to either to continuously take their antibiotics, or stay away from people, or wearing masks. I mean, those are life changes that they have to do for 6 to 9 months, and that's actually pretty hard. So when you do your reading, kind of pay attention to what your patient has to do for the 6 to 9 months, and kind of think to yourself, how hard would it be for you to be able to do that? Because again, these people do actually have it, and you have to give them education, and they won't stay in the hospital for 6 to 9 months. They're actually going to go home. So and they're going to go home to living with the people that they were living so close together in the first place. So one thing you might want to keep in mind is, not only does the person not feel well and came to us or the hospital to get care, but that doesn't mean that the people who they live with didn't also have it. So now you've got a whole house full of people who could possibly have, a contagious disease, and continuously spread it to other people. So there's a lot of education. There's a lot of, reinforcement of taking medications and staying on it and taking it at the right time, and finishing it up. So kind of paid a little attention to that. Let's see here. So the next disease process is COPD. This is a group of lung diseases. So the patient can either have bronchitis or emphysema. Symptoms are shortness of breath, wheezing, chest tightness, chronic cough, cyanosis, and lack of energy. So the shortness of breath is because of the fact that between bronchitis and emphysema, your body is not able to take the air that is consumed and actually turn it into usable air that can actually be throughout the body. So they're constantly short of breath. And because, like I said, it's a chronic condition, and it just gets worse, progressively worse over time. Wheezing is also another symptom that you actually can assess. The chest tightness is because of the fact that they're wheezing and they are shortness of breath. They will always have a chronic cough because they're not able to actually move all the mucus and all the fluid that's actually collecting in their lungs well enough. The cyanosis is because the alveoli aren't working as efficiently, and because of that, it's lack of energy. So The causes of COPD are smoking and irritants. So, I mean, it's obvious. The more you smoke, the more, tar and everything else that's in smoking will cause the alveoli not to work correctly. And the irritants aren't really helping either. So diagnosis would be pulmonary function test, a chest x-ray, a CT scan, and ABGs. Medications for this patient is going to be pretty lifelong. They're going to be using bronchodilators, they're going to use steroids and antibiotics when needed. I always tell this story, but my dad smoked Camel non-filters most of his life. And now he's older and he's got chronic COPD. But he just knows that in the spring and the fall, he tends to get, whether it be the flu or the cold or even pneumonia. And he just knows what those symptoms feel like, and he knows when he's getting worse, and he'll actually go to the doctor. So for COPD patients, it's really a lot of it is, the damage is already done. You're never going to cure COPD, emphysema, or bronchitis, but you can at least give them the tools and teach them what is necessary to actually keep from getting worse. So when they do get sick, teaching them that, hey, here's the symptoms of whether it be the flu or the pneumonia or the symptoms of what could ail them. A lot of COPD patients don't want to be hospitalized, so they kind of wait and thinking they're getting better and thinking they're getting better. And next thing you know, they're just worse to the point where they actually have to come in. So again, teaching them a lot about, what they can do to prevent from getting sick, making sure they're taking their medications on time, especially the bronchodilators, make sure that they're able to open up their lungs as much as possible to make whatever use whatever they do have, make good use of it. The steroids are really just to kind of, cause the lungs to be not inflamed, so they are able to breathe a little better. So next we have bronchitis. This could be anywhere from an acute, which is a few days, or it could be a chronic bronchitis, which lasts for 3 months with cough, or 2 years with bouts of cough. Symptoms are going to be cough, sputum, fatigue, shortness of breath, fever and chills, and chest discomfort. Again, this is a respiratory issue, so they're going to have a cough and try to cough stuff up. They're going to be tired because of the fact that they're short of breath, and they're going to have the fever and chills because of the infection, and the chest discomfort is more based on the fact that they're coughing so much and it hurts. Diagnosis is going to be a chest x-ray, a sputum test, or a pulmonary function test. And medications are going to be antibiotics, cough medicine, and allergy medication. The allergy medication is because sometimes people have bronchitis because of allergens, and this will actually help minimize that and get them better. The cough medicine, again, is either to be an expectorant or a suppressant, or you can actually do both. It's to help either quiet their cough and keep them from coughing so much, or thinning it out and actually allowing them to cough it out. With emphysema, this is damage that has been done to the alveoli, and the cause is going to be smoking. The symptoms are shortness of breath, fingernails are blue and gray, and sometimes they're not mentally alert. These symptoms are probably more of the hospitalized worst case patient, but I have known of people who have emphysema that's chronic, and they do tend to be short of breath all the time. They tend to have the blue-gray fingernails because, that's a cap refill, and their body is kind of constricting blood where it is based on trying to keep it in their core, the central, vascular system. The reason why they're not mentally alert is because they're actually not getting enough oxygen. But again, that's more of patients that are, that 70 to 80%, O2 saturation, that they're not mentally alert. But, they come to the hospital, we give them some breathing treatments, give them some antibiotics, try to open all that stuff up, and give them some supplemental oxygen and stuff, and they can start to come back around. Diagnosis would be a chest x-ray, ABGs to determine what is in there, whether it's their O2 or their CO2, and the lung function test, which is to determine how their lungs are functioning or how well they're actually doing. Medications are going to be bronchodilators, steroids, and antibiotics. Next, we have atelectasis. This is the collapse or closure of alveoli. It's mostly found in post-op patients. This is because patients who have had surgery, the anesthetic goes in. They'll actually get some sort of supplemental O2 while they're having surgery, but it only goes to ruffle nipple line. It doesn't really do deep deep breathing for them. So because of that, the alveoli aren't really working. Let's just call it being sleepy. Give a patient an incentive spirometer and take big deep breaths, and it'll actually start to open all that stuff back up. It's also found in immobilized patients because they're laying in bed or sitting somewhere too much and they're not actually moving around enough to be forced to take big deep breaths, or not moving around enough to actually get the circulation working more efficiently. They're also shallow breathers. So symptoms are shortness of breath, cough, and sputum production. Your assessment is going to be decreased breath sounds and crackles. And the nursing interventions are going to be cough and deep breathe, walking, and turning in bed every 2 hours. And that's the end. So when you guys get to class, you should have read all of the chapters that are necessary based on the different disease processes. Again, this is more of the highlights. If you want to, what I would like for you to do is at some point concentrate on pages 632 to 636. This is the plan of care for patients with COPD. I like these pages because they do actually tell you what nursing interventions are good for different disease processes and why you do them and what you expect to actually happen. So like I said, pay attention to them because like I said, I'm trying to get into that thought process of, we have this problem, this is what I see, this is what we need to do to fix it, and whether or not it actually, worked or not. So, all right, go ahead and bring on any questions you have to class, and we'll probably end up going over ABGs.